It looks like we have pretty much every quorum, so I believe we'll go ahead and get started. I'm Wayne Sullender from the Center for Global Health, and I'm happy to introduce for today two of our own faculty members, Dr. Gretchen Domek and Dr. Gretchen Heinrichs. Dr. Domek received her medical degree from Harvard and trained in pediatrics here. Prior to this, she had studied medical anthropology at Oxford. She also did a global health fellowship with us before she became a faculty member. Her research focuses on emerging technology for global health promotion, as well as promoting early childhood health and development in low-resource settings. Dr. Heinrichs did her medical training and residency in obstetrics and gynecology here. She also received a diploma in tropical medicine and hygiene from the Gorgas. Her interests include maternal mortality, gender-based violence, infectious disease, and refugee health services. She's worked in India, Mexico, Guatemala, Rwanda, and on women's health projects focused on training of physicians, nurses, healthcare workers, and healthcare delivery in resource-limited settings. Their topic today is conducting maternal and child health programs in Guatemala.
Thanks. How's my volume on here? Can you guys hear me okay? All right. So this is Gretchen Domek, so you don't get the Gretchens confused. I'm Gretchen Heinrichs. And we're going to be talking about some updates from the work that we've been doing in Guatemala since 2012, early 2012. So, oh, did I not turn it on? Is that better? Yeah, that's better. All right. So first of all, our objectives. We appreciate that universities are an ideal platform to foster collaboration for global health initiatives. And our example is our CU Community Health Program in Guatemala. What I'm going to be speaking on mostly today from the maternal health side is to understand the value of data for continuous quality improvement within our programs and how you can use that data to target interventions to specific communities.
And then what I'll be talking about is understanding the characteristics of early childhood health and development interventions that we know have the greatest impact, and then how we've used these to be incorporated into our program in Guatemala. I don't know if this is on.
Yeah, it is.
It is? Okay. So I think just to start, we're a public-private partnership in many ways between the University of Colorado and a private banana and palm oil plantation in Guatemala. And here we are located in the southwest Trifino corridor. We're right up against the border with Mexico and the Pacific Ocean.
It's a very poor, kind of flat farmland area that butts up against the mountainous regions of Guatemala. It's mostly coastal plain, basically. So in 2011, October 2011, rapid needs assessment was conducted, and I know a lot of you have probably heard the results from this if you've heard presentations on our project previously. But just to summarize, it included 287 families from 9 different communities in the southwest Trifino. And the key findings were that there were high rates of pregnancy complications. About 30% of women reported a significant pregnancy complication. High rates of childhood morbidity and mortality, high rates of food insecurity, maternal depression, and illiteracy and unemployment.
And then just to kind of give you a little bit of a feel, it's hard to know what it's like without being there, but this would be a typical backyard. So these are where the children have to play, which you can see is not a very safe area. Lots of pigs and garbage. Here would be another typical backyard. Here you can see a typical kitchen, and we do have a water filter that the banana company gave out to over 500 families several years ago, but most of those aren't functional anymore. And then a typical well, and we had a med student test the water in those wells a couple years ago, and they're all contaminated. And then this would be a typical latrine. So you can see, very poor area.
So with that information, we kind of put ourselves together and thought about what do we do about these findings, and how can we attack some of the issues that the communities were facing. So it is very much a team effort and has been multidisciplinary, lots of different colleges within the university who've been collaborating on this.
I hesitate to use this slide, but I always use it because I know I forgot people, but I think you can see all the different schools that are involved, and there's certainly people we've left off. So we've really modeled our program after the 1,000 Days campaign, which is a WHO partnership that recognizes what they call the window of opportunity to improve nutrition for mothers and children in the 1,000 days between when the woman starts her pregnancy and the child's second birthday. And this program promotes targeted actions during a period when we know that better nutrition can have a life-changing impact on the child's future and break the cycle of poverty. We are really the 1,365-day campaign because we go until the child's 3 years old. But this is largely what we've been modeled after.
So we have three main parts of the project, and within each huge project itself, there are many aspects to those projects. So I'll be talking about Madres Sanas, which is based upon a birth registry that we started in November 2012 with faculty and students from the School of Public Health. And Gretchen will talk later about Niños Sanos, which started enrolling children in their registry kind of the following year. And then on the ground, there's an infrastructure that exists, which is a health clinic that opened in March of 2015. And then we've been working diligently and persistently to try to open our birth center, and we're hoping that it will open here in early 2016. So go into the Madres Sanas program. So the pregnancy registry that we already sort of described, but basically it collects information from each of the 4 visits, prenatal visits that occur during the pregnancy of the woman, and takes that information. It's uploaded to a secure cloud, is transferred here to the university, and that data can then it's de-identified for the most part, and is then available for us to evaluate our program milestones and our accomplishments, and also some of the things that perhaps are not going so well. We do have IRB approval for that as it's a QI database. Within the Madres Sanas program, the first arm that was rolled out with the pregnancy registry was providing prenatal care to women. So we knew from some initial surveys that very few women in the communities completed the recommended 4 prenatal visits that the WHO has suggested are the minimum. And so we really are trying to improve the percentage of women in those communities that achieve that 4 prenatal visit level. And we do that because there is a lot of poverty, and the transportation is a significant issue in these communities. We bring the prenatal care to them. So I've trained, along with my team, some nurses from the communities who then go and deliver the prenatal care in the women's homes or via group prenatal care, which we'll talk about in a little bit. We have also done a traditional and skilled birth attendant training program using simulation. I don't know if any of you guys have seen the Mama Natalie's. Have you? You ever seen one of those? Well, you'll see one shortly if you haven't. But those are great training tools that you can use to practice emergency obstetric skills with the folks in your training programs. And we used them especially with low literacy traditional birth attendants. They've been incredibly useful. And then hopefully we'll be opening the birth center here shortly in January 2016. Okay, so how have we used the data that we've collected? So it's, it took a lot of effort to collect the data, to set up the systems, to get the data transferred over to the university for us to evaluate. But it's not responsible then to not do anything with that data and let it just sit there and accumulate until you feel like you come up with a research question to look at with it. So what we have done is done an ongoing, like twice a year, trying to come up with some sort of quality improvement project that we can look at the information that we've collected and really assess whether there is something that needs to be improved within the programs or something that needs that could be extended or done away with. So we'll go through 2 studies that are kind of investigations that we've done into the pregnancy registry, which are factors associated with skilled birth attendants, and the neonatal referral practices of our nurses in our communities. Then we'll go through prenatal care delivery in the communities very briefly, some of the group care and quality improvement visits data, and finally some data that we have on our traditional birth attendant and skilled birth attendant training program. Any questions so far? Okay. All right, so pregnancy registry. So what we did a retrospective secondary analysis. Let me step back. Currently, there are more than 500 women in the prenatal registry. So when you have to freeze the data at some point to analyze it. So when we froze it last March to analyze, we had about 292 women who had complete data for which we could analyze. So we looked at the rate of facility birth in the cohort, which was 66%, which is a little bit higher than the Guatemala national average, which is around 55%. And the rate of C-section in our cohort was 31%, which is quite high. So that includes all the women who also delivered at home. So not only those who delivered in the facility. So it's a fair. So if you imagine 66%, a high rate of those women who end up going to a facility end up with a cesarean section. Maternal factors that ended up being associated with facility birth, the main one was spouse or self-employment at the plantation. So the employment allowed women to access facility birth care. So they have to understand the setting, you have to basically take a bus or some sort of private vehicle about 45 minutes to get to the nearest hospital where you could have a C-section. So if you have to travel that far and it costs 2 months' wage, 2 months of your husband's wage to take a private vehicle, not many women are going to access that care unless they really need to. And so women who had access to larger economic resources, including via this employment at the banana plantation, they were able to access that care to a higher degree. If they were planning a facility delivery, for some reason, perhaps they had a C-section last time and they were going to have another cesarean, maybe they would, so they had a higher rate of facility delivery and a higher rate of maternal complications were evident in the facility. The factors that were not associated, which were interesting because the global literature has really shown that all of these 4 factors are highly associated with delivery in a health facility. So distance from the hospital, maternal education parity, so the number of children she has delivered, and completion of 4 prenatal visits. So none of those were associated with a higher likelihood of delivering in a healthcare facility in our cohort. There were no maternal mortalities, which was wonderful. We have an overall population of about 25,000 that we're drawing from, so we wouldn't anticipate any maternal mortalities in that group. But, things happen, but so far we've been lucky in the women that we've been following. And there's no difference in the rate of neonatal death or subsequent neonatal referral, whether the woman delivered at home or in the hospital. So that kind of speaks to the fact that you're probably getting a lower risk population delivering at home, and their babies are going to do fine no matter who's there and who's providing their care, and a higher risk group of women self-triage to a health facility where they need to be for their care. So that's just to summarize what we learned from this investigation was that we got a better idea of who is our birth center audience when we're trying to recruit low-risk women to deliver in our birth center. Who are the women who are going to stay? It's that 30% population that's already delivering with the traditional birth attendants at home, and some of those women who may be low-risk but went to the hospital because they were unsure of how they would do, and maybe some of them ended up with a C-section because of the care that was provided during that time. So, and again, there are economic factors that are primarily contributing to access to care for this population. In terms of neonatal referral practices, this was one of our fellows, Tim Insel, did a QI inquiry into around 336 of the live births that were available in the data at that point. 12 neonates were referred in that population, which is probably on the low side. So we're not sure this was the initial stages of the pregnancy registry, and so we're hoping we're capturing all of those referrals that really needed to happen, and so we'll kind of be looking at that going forward. Of those who were referred, the most common causes were difficulty breathing, fever, icterus, and jaundice, difficulty feeding, and one referral that was for an unspecified cause, and some children were actually referred for multiple reasons. The condition that was easiest or most completely referred for was jaundice, which is pretty, you can understand why that would be. You're going to see it. It's an obvious sign. Whereas difficulty with respiration, counting rapid respirations in a neonate is quite difficult. And so, and checking fever in a neonate can be quite difficult as well. So some of those cases were missed, we felt like, in the referrals, but jaundice was the one that was easiest for our nurses to refer. And then, interestingly, most of the cases that were referred had been delivered at a health facility by a doctor or a nurse for a facility birth. But 33% of the referrals were from neonates who were delivered by a comadrona, which is our traditional birth attendant. There were 6 neonatal deaths, there were 6 mortalities, 2 of which were miscarriages or terminations for sepsis or a maternal indication. 4 were actual neonatal deaths, and 1 was delivered at home by a comadrona, and the other 3 occurred in a hospital. So if you look at the deaths, what's most interesting is that this talks about malformation of the head, limp limbs at birth as the reason for death. And what that may suggest is that this was a fresh stillbirth. So this was a baby who should have been more carefully monitored during labor, and this death could be prevented with better obstetric care and better monitoring of the baby in the labor. These also, though, are concerning because they are deliveries that occurred in the hospital and underwent cesarean delivery with neonatal death. So you wonder if there was preterm labor, was there infection or sepsis, and the baby died then mostly because of that, or was the labor not monitored well, because they also commented that there was suffering, non-reassuring fetal heart tones, prolonged labor, meconium, so some sort of fetal distress. And then these are unspecified, but you do note that there was a hemorrhage and a breech delivery and another breech delivery, and both of those ended in neonatal death. So you look at the demographics of those who had deaths, and 2 of them had more than 4 prenatal visits, and 2 of them had less than that. We don't have enough numbers to really draw any firm conclusions or significant conclusions from that data. Any questions on those studies so far? Yeah.
So you can describe what the nearest hospital that these women are getting care at is like.
So in Coatepec, which is the nearest town, it's maybe 100,000 people. And they have one main public hospital where they can receive care for free. They do sometimes have to have lab results if they show up there non-emergently. And so they may have to go pay for some of those labs and then come back and present those labs or ultrasound results to receive care. But if they come in an emergency, they will be seen, they will be taken care of. It can be extremely crowded. The beds it's one big labor ward with beds kind of lined up along one wall and then the other. And then the women also and they have residents, OBGYN residents who are attending the majority of these deliveries. And there are attendings in-house who are available as well. So, and then within the community, there are about there's 2 main other private hospitals, but then there are also smaller kind of private practice hospitals that they can do cesarean sections in some of as well. And so when we're saying a private hospital, it's one of the smaller hospitals where those deliveries are occurring. And it's even possible that the physician wasn't there at the time when the patient came in, or wasn't managed by a physician. They were managed by nurses, and then the physician was called when they noticed that there was a problem. So we don't know all the details on it. It's extremely hard to get that information, but we're trying to get an idea of what's going on in the communities. Yeah.
Do you have, of the C-sections, do you have any idea how many are repeat C-sections and how many are primary?
I don't have that data. I would love to know that. I'm sure we could look a little bit closer into that. A lot of, I'd say probably 50% or more of girls less than 18 receive a C-section. In what I've seen so far. So there are definitely, Guatemala has the highest rates of stunting, some of the highest rates in the world. And so that may also correlate with that rate. But a lot of women do choose a repeat C-section once they've had one C-section. So there's not a lot of trial of labor after cesarean. Yeah.
I'm curious what the cultural baseline was before you started this project of cultural or religious perspectives on childbirth in a facility versus an attended birth at home versus an unattended birth at home. I'm just curious what the...
So we did inquiry into that the year prior before we started all of this, before we started designing the birth center and trying to understand what women would want and what the traditional birth attendants would also be involved in. We wanted to, this is a major source of income for them and for their families. So we didn't want to throw them out of the picture, and we wanted to collaborate with them, improve their practice if we could. And a lot of them are illiterate, and so raising their level of education and complex medical decision making you can only get to a certain point with that. And so what we did was we did a qualitative study of birth kind of practices and beliefs in the communities. And, it was very diverse, but a lot of women do want to deliver at home. They're afraid of the hospital for multiple reasons. Either they can't bring someone who can support them with them into the birthing room. They're there by themselves. They're in pain. There's no pain control methods. So, a lot of them do want to stay home for that reason, but they also realize that there are risks to birth and that they may need a hospital at some point. So we did a lot of work on the ground before that, before we started this.
That sounds challenging.
It was.
That was not nothing.
No, that was a very difficult study, and so it was like a collection of narratives, basically, that we've done. So. Okay, I'm going to go through these fast because I don't want to take time away from Gretchen. So we've started group prenatal care since the fall of 2014, which is basically trying to get a group of women, somewhere between 6 and 12 women from a single community who are pregnant, to sit down together and learn some concepts. So we've designed 4 different prenatal visit educational components to the 4 visits. And this is one of the games that Kelsey, who I saw earlier, helped create. She did such an awesome job. So this is, because it's kind of just boring to sit around and talk about nutrition, and we had the women basically play a game where they're grouping different pictures into what the categories are, so that they understand proteins versus fats versus vegetables versus foods they should probably avoid during pregnancy. We also have a game that we're about to pilot that is prenatal care. We did a study of family planning, like myths and misconceptions in the communities as well, in order to design an educational program that would relate to those topics. And so this game will actually hold up a myth, and then the rest of the respondents in the group have to say, is this true or is this false? And then the nurse, who you can see here, she facilitates the discussion, and then she has a little bag of tricks so that she can show people the different methods. The majority of the communities use Depo-Provera. That's the the medicine that's used most commonly, mainly because it's the easiest for folks to access. So we also do traditional birth attendant and skilled birth attendant training programs. This is just a couple of pictures. This is the mom anatomy. You wear it. There's a baby inside. It also can bleed. It has a lot of really cool functionality. It allows you to kind of squeeze something to make a firm fundus afterwards when you're massaging after your delivery. So you'll get to practice them in the upcoming tropical medicine course, so I hope you guys get enrolled in that so that you can play with that. I'm going to show a quick video that just shows how we use it with our traditional birth attendants. These were a group of the same group of traditional birth attendants that we've been working with the whole time since 2012, and they are doing a shoulder dystocia maneuver exercise. So just to set it up, we give them the scenario like you're at home, you're the only healthcare practitioner in the room, your patient's delivering, and you need to do the maneuvers and access any help around you, draw in the family or whoever's there, and just apologize for the Spanish. So they're raising my legs there because that's one of the maneuvers, and she's doing suprapubic pressure which we taught them to try to resolve the shoulder dystocia when the shoulders are stuck. And then flipping you over into the Gaskin maneuver to try to get the baby out. And so those were the 3 maneuvers we taught them. You can see how much I'm sweating. It's very hot. When you give birth like 12 times a day, it's really pretty hot. So we did a brief study with using the objective structured clinical exams, or OSCEs, to determine if the trainings that we did were actually improving results or improving knowledge and improving skills. And the data showed that there was a significant improvement post-trainings in our in both the shoulder and postpartum hemorrhage trainings. Interestingly, the postpartum hemorrhage training was much more complicated, so we didn't see quite as much of an increase with just one training. And so we've done these trainings over and over now to try to improve the outcomes and long-term use of these skills by the traditional birth attendants. So then we've also brought this to our skilled birth attendants at the Pesce. This is the yearly OBGYN resident conference that they have done in Pesce. So we have done the shoulder dystocia training with them. This is us with our mom and Natalie's. And then Suseli and Marco's here, he's over there. So Marco and Suseli have basically helped Amy Nacht and Anna Williams and I to implement a ongoing training program. And Suseli basically runs these mock drills every 3 months, at least one of the topics. So each month something gets visited. So either shoulder dystocia, postpartum hemorrhage, eclampsia, and safe delivery techniques. So, all right. I think that's it for me.
Is this working?
And then you can help me.
Okay. All right, so I'm going to talk about the second part of our program, which is the Niños Sanos. So after the child is born, then they enter our part of the program. And I first want to tell you a little bit about background information about how we went about creating this program. So what we've known from the literature, and then some of the pilot studies that we did to learn more about how we were going to implement this. So if you look at just very broad categories of childhood well-being, they would be health, nutrition, and development. And these are all obviously very closely related. And when we look at other global research that has looked into early childhood programs, we know very clearly that integrating these 3 components is critical. So if you have a program that just looks at nutrition versus a program that just looks at development versus a program that looks at both nutrition and development, we know that we'll have better growth and better developmental outcomes in that joint program. And then there was a good study that came out in 2007 that kind of outlined several characteristics that we know have the best outcomes for early childhood interventions. So as I said, integrating health, nutrition, and development, but also occurring during the very earliest periods of life, which we think we do because we even do it during pregnancy. Providing both direct services to the child and support and education for the parent, and then utilizing several different types of interventions and including more than one delivery method. So knowing all of that, you'll see how we developed our program. So then we did two critical pilot studies to look at how we were going to go about creating Niños Sanos. So the first study was done in July 2012 with me and then a couple of medical students. And we looked at 75 children between the ages of 1 and 4 years old. We did demographic surveys, and then we did developmental screening with what's known as the Ages and Stages Questionnaire, or the ASQ. We use this a lot here, and it's been used in several other countries. One of our biggest issues with this program is finding a tool that we can use in another community like where we are. So we felt that the ASQ is one of the most well-known and used around the world. So it's a 30-item questionnaire that's usually self-completed by the parents. Because we have such high rates of illiteracy, we had our community health workers complete this with the parents. But it looks at 5 developmental categories in the child: communication, gross and fine motor, problem solving, and personal social. So in our demographic survey results, we learned much of what we already knew. So about a third of the mothers were illiterate and could not read or write, and about a third of the mothers had not received any formal education. And then we asked a series of questions about stimulation. And we found that many of the moms aren't doing stimulating activities with their children on a consistent basis. So about half the moms said that they read or looked at books with their children, but only 16% did that at least 3 days a week. And when we asked about telling stories, which anyone can do even if you're illiterate, about 65% said that they would tell their children stories, but only 15% did that more than 3 times a week. So then when we looked at our results, according to the ASQ, we had many ASQ-defined delays. So more than 50 or 59% of children had at least one of the 5 categories delayed on the ASQ, which is a very high number. And you can see 9% of children had 4 or 5 of the categories delayed. So lots of ASQ-defined developmental delays. And this is, again, just a screener, so it's telling us children who are likely to be developmentally delayed. And then the most interesting part of this study for me was when we looked at several of the risk factors that we'd explored, and then looked at the impact that had on frequency of having at least 2 delays on the ASQ. So what we thought we'd find, we did. So if the mother was illiterate or had a primary education, then those children were more likely to have fewer than 2 delays on the ASQ. So those were protective factors. If the mother had 3 or fewer pregnancies, those children were less likely to have ASQ-defined delays. So again, perhaps if you have more than 3 children, those resources, the limited resources that these families have, are being spread out to more children, and so each child is getting even more limited resources, and there's probably less one-on-one attention being able to be given to each child. But then so those are kind of what we thought we'd find. The most interesting part was when we asked, do you play, or someone in the house, play with toys with your child? Those children were, if the mother said yes, someone plays with toys, those children were much more likely to have fewer than 2 delays on their ASQ. And if the mother said, no, we do not play with toys, and those children were almost twice as likely to have 2 or more delays on their ASQ. And the same when we asked, does anyone read or look at books with your child? And all of these were statistically significant, except for the reading books, which was close. And then the next part of the study, we did a very brief intervention. So we presented a brief flip chart talk that we had 2 of them, between 1 and 2 years and 2 and 4 years, that looked at language development and discussing dialogic reading, or how to most interactively read with your child. And we did videos pre and post the intervention. So I want to show you this pre-intervention video. So at this point, we just handed the mom a book and said, read to your child, and we took a video. And watch the interaction. So it's not bad. She's pointing to the objects in the book, and he's maybe a little interested. He's trying to flip the page, and she's kind of swatting his hand to see what she's showing him. So after we gave a brief 30-minute talk to the moms about how to interact while they read, now watch, a week later we gave her a book and asked her to read as well. So that's him mooing like a cow. If you can't understand what she's saying, here she's saying, this is a cow, what does a cow say? And then he said, And she said, this is a bee, what does a bee say? And he's buzzing and he's repeating it. So you can see she took the child, put him on her lap, did all of this without us telling. We had given that talk a week earlier. But you can see how much more interactive that is, how much more engaged he is between both the mother and the child. So from that study, we took home a few points. One, we felt that delays were probably very prevalent in the Trevino region and were a big problem. Two, we felt that when we could correlate or look at the associations between our risk factors and our delays, that there were areas like playing with toys, very simple interventions we could do that might make a very big difference in that child's developmental trajectory. And then three, that these short flip chart talks, the mothers were really able to learn from those, and you can see how much she incorporated that into reading with her child. So then we went back a year later as we started making our material, and in July 2013 I took a couple other medical students down with me, and this time we tested a couple flip chart instructional talks with the mothers. And so we had two different talks between 0 to 6 months of age and for children between 6 to 12 months of age. And these cover different topics relevant to those age periods. And then what we did were learning assessments. So we did about a 25 questionnaire of questions that are covered in this talk before the flip chart talk. So those were the pre-questions, immediately after we gave the talk, and then 1 to 2 weeks after we gave the talk. And in between, we never gave the mother the answers to any of these questions, although they were in the flip chart talk. And in between those two posts, so that 1 to 2 week after the flip chart talk, they had absolutely no interaction with our material. And so here you can see a couple of the med students and the community health workers. We trained them, and then they gave all of the talks. So our students are observing there, and one of the community health workers is giving this talk to a small group of 5 to 10 mothers. So then when we did our learning assessments, this is for the 0 to 6 month flip chart, we had 38 mothers complete the learning assessments. In the first pre-learning assessment, they answered about 75% of the questions correct, which we felt was pretty good. We didn't want this to be all new material, so they kind of started at about a C. And then after we gave the flip chart talk, we did our next learning assessment, and that number increased a little bit over 85%, so correct. So again, we felt that that was good. They learned and gained about 10% more correct on average. But then what was most interesting, when we went back 1 to 2 weeks later to see how much information they had lost in that period, we actually found that they didn't lose any information. They increased their knowledge. So now, 1 to 2 weeks later, without any more interaction with that material, they increased to 90% correct, which was very interesting. But then the best part is when we repeated this with a whole different group of mothers and a whole different flip chart talk, the results are almost identical. So we felt, so this was with the 6 to 12 month flip chart talk, and again you see that bump in the 1 to 2 weeks after the first and second post learning assessment, which is very interesting. So to us, we felt like these group talks were really important, and that probably what we hope is happening is the moms are going back after we give the talk, they're talking to each other because all of these moms are in the same community, and they're reinforcing the material that they learned, and they're able to practice it, and then 1 to 2 weeks later they actually know it even better. So given all of that, we then went about creating our part of the program, Niños Sanos. So we have, as a broad overview, we have 3 neonatal home visits. These are all done one-on-one at individual homes because the mothers culturally do not leave their home in the first month after birth. And then we use our group health visits. We have 4 of those at 6, 12, 24, and 36 months. And then we have 35 interactive care groups monthly between the ages of 2 to 36 months. So if you complete this program in its entirety, you have over 40 visits. So in our neonatal visits, which is one of the most important parts of this program, there's 3 of them. One is the birth visit, and we really want to get this at 3 days of life. This has been one of our biggest targets because it's hard to know exactly when the child's born, and sometimes they're not, if they're in the hospital, they're not always back at the home, or they're staying with the mother or the mother-in-law. And so getting this visit done within 3 days of life has been a real challenge, but you'll see it's what we consider one of the most important parts of this program because that is the most important period where those children we know will die when we have neonatal deaths. We then have a 2-week visit, which is the same as the birth visit. So these are community health worker assessments of 8 different danger signs. And then we also do growth monitoring to make sure the child's gaining weight. And then we do postpartum depression screening with the Edinburgh postpartum depression screen. So we do that at both the birth and the 2-week visit. And then the 1-month visit, when the child's a little bit more out of the danger zone, we do a flip chart with anticipatory guidance with the mother. And these are all one-on-one between a community health worker and a mother. So it's also an important period where the mother can really bond with that community health worker who she will then be working with for the next 3 years. So the reason why the neonatal visits are so important is because if you look at deaths of children under 5 years of age, slightly under half of those deaths occur in that neonatal period. So it's really critical. And then when you look at that first month of the neonatal period, it's those first 3 days when the children are mainly dying. So if we can get that first visit happening within 3 days of life, we feel very strongly that we can get neonates referred to the hospital who are in danger of dying. We then have a series of group health visits at 6, 12, 24 months, and 36 months. And these kind of mimic what well child care would receive here in the U.S. So it's a flip chart with anticipatory guidance. We do growth monitoring and promotion. Developmental screening, we're still using the ASQ, and then we verify the immunizations that they're getting at the health post. And so here you can see our community health workers measuring a child, giving one of the flip chart talks. And then a big part of our program are these monthly mother-to-child care groups. So these happen from 2 to 36 months of age. So again, there'd be 35 of them if you completed the program in its entirety. And the first part of this session is an activity that focuses on primarily language and other developmental areas. So some gross motor stimulation, nutrition, and we use the language power that Bonnie Kemp developed and learning games through the Bright by 3 and Abecedarian curriculum that are evidence-based. And then we always spend 5 to 10 minutes reinforcing a health topic, something like diarrhea, cough, pneumonia, hand washing. And then we always do growth monitoring and promotion as well. So we do weights, heights and lengths, head circumference, and mid-upper arm circumference. And then there are referral guidelines for both the growth and the development. And so this is one of my favorite pictures. This is Edwin's wife teaching a care group session. And I love this picture because we know that there's lots of maternal depression, and it's one of the things we're looking at in the Trifideo. And when the mothers come to these groups, they often have very flat affects at the beginning. But if you look, every single mother in this photo is smiling or laughing. And that's what happens then as the program and activity carries on. And the children have fun too. These guys are a little more serious, but they're 6-month-olds. So this would be one of the activities we do in the first 6 months. And here's another example of an activity. So we take empty water bottles, put corn in the water bottle or rice, and we make a rattle showing them that you don't need to have fancy toys or lots of money to buy a toy. There's water bottles laying all over the ground, and everybody can find a little bit of corn to put in it to make a rattle. And when we did, this child looks a little skeptical too, but they did grab these and start playing with them. And then one of the newest additions we've done at the suggestion of Bonnie Kemp is to have these finger puppets. So we're trying to train the moms or teach the moms to talk and interact with their child more, which is not intuitive. Even here in our culture, it's not intuitive to talk to this baby that's not going to talk back to you, but those children need to hear words. And so what we've done is given the moms, every mom gets a finger puppet to take home and keep. And you can see here, they're right in that baby's face talking. And so this is what we're promoting in the first year. So currently, we have over 700 children enrolled, and I think that number is a little bit misleading because that's any child who's had at least one visit. And at the beginning, we've had turnover with our community health workers, and I think there was a sense of the more children enrolled, the better the program looked. It wasn't the quality of the enrollment, so these children weren't getting the proper visits. They were just all getting enrolled so they could say we have 700 enrolled. But I think one of the best numbers is we have 150 new participants enrolled since June. So we know now we're enrolling children who are carrying on in our program. Over 300 children have had a nurse visit in the first month of life, and over 150 have had a nurse visit in the first week. So that's really good. That's what we're aiming for, and I think we're heading in that direction. One of the clever things maybe we did, I don't know how clever it was, but we had such a hard time getting that nurse visit in that first week, and so we offered an incentive to pay the nurses more if they had more nurse visits in that first week, and guess what happened? There were more visits in the first week. So I think that was pretty powerful, and we're starting to get where we want to be. We've also expanded our telehealth program, which I think could be really critical. It costs a lot to send a big staff from the University of Colorado down there several times a year to do the training, and if we can do some of this via telehealth, we can probably save money. So we have been developing weekly telehealth trainings on lactation and other child health and development topics. And then we actually canceled our September trip and did it from here. So we did it via Skype. We did a 1-week training. And that seemed to go pretty well. We're going to go down in December because you need to go and watch them in the field and see how they're doing the activities. But we were able to train them from abroad, and we'll see if that worked. And then, again, I hesitate to put these up because we have so many people who've been a critical part of our program. Lots of medical students we've used, School of Public Health students. We have a new telehealth education team. And then for the child part, we've had 2, I call them consultants, but retired physicians who have really helped us a ton. So Bonnie Camp has been helping us develop all of the developmental activity parts of the program. And then we decided 2 Gretchens was not enough. There should be a 3rd. So Gretchen Berggren has done all of our nutrition monitoring with us. And I don't know if you want to say anything about it. There have been lots of midwives and nurses.
The model has basically been that we have a global health elective for OBGYN residents, and they do a research project as part of that work. And so some of the data that I presented today, or some of the projects that I've mentioned, have been their work carried out in the Trifinio with our guidance. So really involving the residents and students allows us to reach a lot further and accomplish a lot more than we could accomplish on our own as faculty. So it's been incredibly helpful. And then the midwife volunteers are hopefully just a growing number. When we open the birth center, we're hoping to have a rotating group of midwives that will come down for a 2-week volunteer stint each month to 2 months and do on-the-ground training with our nurses who we've trained on the ground there to deliver the babies under physician guidance. So that part of the program is growing and still needs to be actualized. So.
And because we were tasked with telling you about this and all of this in just 50 minutes, we didn't talk about the clinic, but there is a clinic that's now open that has a lot of interaction with everything that we do. Not just the birth center part of the clinic, but we can also, so all of our referrals we can now send to this clinic in the Trifinio, which is huge. So I think in conclusion, one big takeaway that I hope you were able to take away is that universities are really such an ideal platform to foster this kind of collaboration for global health initiatives. Our clinic, part of our clinic was designed by our School of Architecture. We've had the School of Business involved. So you have all these different areas, health, business, architecture, anthropology, the social sciences. Everything has been at our disposal to use, and we've really utilized all these different programs. So I think, when you look at NGOs that don't have access to all of this, we as a university are in such a unique position to take advantage of all the different schools and knowledge that we have available to us. And then as part of that, the University of Colorado is embarking on this collaborative effort that I think has really used that ideal platform and has served as a unique model for that to develop the clinic and the community health program we just told you about in rural Guatemala.
And really, the data is the key to us continuing to improve and evaluate our programs and make changes as we need to better serve the communities and really keep it a community-based project at its foundation.
Perfect. Great. So we made it with our 10 minutes for questions.
And I do want to just acknowledge Vincent, our resident from Rwanda, who's visiting. So I got to meet Vincent when I was I think second year faculty, and so I got to go to Rwanda and work with Vincent and his other colleagues, and it's just so wonderful to have him here. Welcome.
Thank you a lot. And this is also an opportunity for me to say thanks to all the Colorado University community, because if now I'm a family physician, I think it's because of what Colorado University has been investing as faculty and all the resources to make all this possible in Rwanda. Thank you a lot.
Any other questions, anyone?
Perhaps as I had the microphone, I could also ask a question.
Oh, sure.
Yeah.
Yeah. I just was curious, in the Trofino region, what is the primary language? Is it an indigenous language or Spanish?
Spanish.
Yeah.
So we're blessed because it's all Spanish.
Wow.
Yeah.
It's hard enough for me to speak Spanish. I couldn't handle it.
Yeah.
I have 3 questions. The first is about a tool you used, a questionnaire. I think you call it
Cute.
ASQ.
from WHO, or an international questionnaire, I think.
No, it was developed, I believe, out of Oregon. It was developed in the United States,
Yes.
but it's been used all over the world.
And the question is this: was it already adapted in Guatemala, or did you went through an adaptation, cultural adaptation of the tool before you start using it?
So it's an excellent question, and that has plagued us for a long time. So we didn't, because to go about designing and implementing this program, we haven't had time to take the tool, adapt it, and then validate it, which would take us a long time. And so we've just used the validated version in the U.S., but it's not validated for our population. It's not adapted for our population. So all of those results have to be taken with a little bit of caution. But there isn't, the WHO is in the process of making a developmental tool. It's going to take a long time, and so when they do, we hope that we could use that. But it's hard to find. So this tool we felt like had been most frequently adapted or used in other populations, but it's not adapted or validated for our population. So it's a very good point.
Thank you. Then the second question is about the use of community health workers. You've been using them, community health workers. Are they community health workers integrated in the public system that we have been using, or is it a parallel group of community health workers? And in the first case, if it's, I don't know, what is the case here?
It's they're from the private sector. So the public health, community health workers are, we had trouble integrating with their system within the Ministry of Health. So we actually took on an existing project that already had a structure of community health workers, and so we trained them additionally to deliver some of the child and maternal interventions on top of what they were already accustomed to doing, which was mostly just child weighing and measuring.
Okay,
So.
thank you. Then the last question, sorry that I have many questions. It was very exciting presentation, very relevant, I think, also. Because we also have such similar interventions, written in Rwanda. And the last question is about about thinking about sustainability of such program. Are you training or some other people in terms of continue such project, in terms of also being able to conduct qualitative? How do you call it again? Conducting some kind of quality improvement project and also research. I don't know if you are thinking about that also in the project.
That would be a wonderful long-term goal. Mm-hmm. I don't know if anyone wants to say anything about it, but this is a long-term partnership. That's a 5-year collaboration that with the initial monies and partnership. And so with the eye to sustainability, the things that can help fund some of these projects that won't make money and that really are our community public health interventions, our model has really been to look for research opportunities that allow us to have some funding for some of the infrastructure that exists there on the ground. And so we have a dengue study, a diarrheal illness study in children, and those studies have really allowed us to help augment the infrastructure on the ground so that some of these programs can go on. But the funder is giving some of the money that is coming from the funder is used then directly for program support. And so that kind of fills in the gaps. That funding is not limitless, though. So at 5 years, it'll end. And so we really only have 1.5 years to 2 years, I think, left. And so we're looking for ways to find the solutions.
Yeah. And one thing that we didn't go into, so we have a very robust data collection system. We use a ODK on a telephone. So our community health workers go in. Every one of these visits, they are collecting pages of information on different activities, the growth, all of that, the ASQ results. And so we have lots of data that hopefully we can also start showing that we're making an impact.
I have one question. When you have the group meetings and all, are you also collecting qualitative data from your group observation and all the response of the member and all?
Yeah, so at the end of every visit, we have the community health worker fill out kind of a blank page on how things went and improvements, and then we have our data collection during it.
And that could be used, those papers could be examined in the future, and they don't have very, in-depth observations that you would find if you had a researcher on the ground observing the interaction, but they make some comments about, like, how did the snack that you used work? How many moms attended? Were they engaged? Did they like the topic? Did they like the game that Kelsey created? So things like that that could be evaluated in the future.
But we've used those. Something as simple as a snack we discovered was critical because we got a lot more moms to come if little crackers and a thing of water. It's really hot there and they're sitting there sweating and we weren't giving water for the first year of the program. So just a simple intervention like that has really helped the session go better, and I think moms are coming more because of it. So that kind of stuff, when we can review it every time, has helped. But I've been amazed at how many little things have made a really big difference.
And just one final thing from my aspect. This is a process that is reevaluated on a weekly basis. We go over the data every single week with the report. It's a very brief report, but we are looking at those patients who have high-risk conditions during their pregnancy. We review those on a weekly basis, and we talk. We send a report and interact back with our nurses on the ground via messages or email or Skype, and make sure that they're taking care of those patients that we're especially worried about. So it does take a lot of ongoing management of the project. So. Yeah.
So I saw one of the things that you're collecting is vaccine records and confirming that children have been vaccinated. I was curious what kind of percentages or numbers of kids are actually getting their vaccine, especially since some of the health posts are closed. And are you guys thinking about any ways that you would intervene or try to improve that?
Yeah, so we haven't been able to look at that data yet. So I don't know. It'd be very interesting because there have been such vaccine shortages over the past couple of years, and we could go back. We've been collecting the data. We've had some problems with the quality of the data being collected, so they're able to skip over questions. So if the mom doesn't bring her vaccine card, they're skipping over those questions because they don't have the dates. But they're supposed to go through and enter the dates on everything. So ideally, we would have all of that. And then we do have our SMS study. So we have a study starting in the next couple of months to send reminders. It wouldn't be specifically for our program, but for the area. And any child who hasn't had a vaccine should be getting referred to the health post to get their vaccine.
But you definitely, within the data, on my weekly report, I have a report of how many women who were enrolled this week had their tetanus vaccination series up to date during their pregnancy, and those numbers decreased significantly during the time that the vaccine was no longer available at the health post to around a 30% level. So it's really concerning when you know that the best interventions are not being offered.
Really great for this one.
Yeah, we better stop.
You guys